Thank you so much for everybody to be here. I know it's difficult to be away from family and all your commitments, so I really appreciate your time being here. So I'm Pavni Kolakalapudi. I go by Dr. K to make things simpler. So today we'll be talking about how to use evidence-based, personalized cardiovascular, all the CT imaging that we have to really drive personalized individual patient care. So we'll be talking about guidelines, best practices, as well as understanding what CT imaging can add to that guidance. So I have no relevant financial disclosures. So the objectives today, we'll really try to understand the role of risk enhancers in routine ASCVD assessment. So we'll go understand beyond calculators, what else can you use to guide that treatment. We'll also use how a coronary calcium score can aid in helping your patients drive down what their risk actually is. And also, we'll also talk about the technology that's there available to us and that keeps growing all the time, which is CT angiography. It's also with AI, as well as identify who is appropriate patients for these kind of testing. So I feel like we're giving an AI in medicine talk today as well. So this is from the ACC guidelines for atherosclerotic risk assessment. As you can see, this places patients in kind of low, borderline, or high risk or intermediate risk. I kind of want to tell you about this table on the right-hand side that shows ASCVD risk enhancers. Your risk enhancers can really drive down those borderline or intermediate patients and add context that's personal to the patient themselves. Those can include family history of premature atherosclerosis, which could be like a brother with an MI in their early 50s, female patients with the risk factor of MI less than 65, and again, high risk in South Asian ethnicity. South Asian ethnicity by itself is an independent risk enhancer for ASCVD risk. Also, conditions are specific to women. History of preeclampsia or history of early menopause before the age of 45. They can always be kind of overlooked when you're doing a routine physical exam with a patient, but also just keep in mind this does add context to their risk. Again, some lipid management keys that can also predict ASCVD progression. A general cholesterol or LDL greater than 160 or persistent triglyceridemia also should point you towards an underlying risk factor that could be available. Again, concurrent high-risk conditions like an ankle-brachial index less than 0.9 and chronic inflammatory conditions such as rheumatoid arthritis, lupus, vasculitis, and also some infectious diseases such as hepatitis C and HIV can also add to your risk assessment of the patient, as well as metabolic disease and chronic kidney disease or history of kidney transplantation. Biomarkers, if measured, elevated high sensitivity CRP, elevated lipoprotein A, and elevated lipoprotein B. The lipoprotein A is probably the most particularly nefarious one because there's not really targeted treatment to treat the lipoprotein A. And also lipoprotein A is implicated not only in heart disease, but Dr. Al-Sakir just mentioned aortic stenosis has also been shown to have somebody progress to aortic stenosis sooner if they particularly have lipoprotein A. ApoB can actually also be a genetic modifier, but also can diet and exercise and lifestyle prevention can go a long way to control this without medication. So that's kind of a way to differentiate between ApoB and lipoprotein A. Again, we've talked about how these risk enhancers that we discussed can add to your low risk or borderline patients and kind of actually take them to most appropriate way. And also adding calcium score to that assessment. So again, we come back to this calcium score and it's hard to convince a patient, hey, your risk is 15%. You have to take this new medications. Oh yes, don't go on the internet, don't go on TikTok. It has a lot of bad news on it. But when you actually do this imaging, calcium score, very cost effective, about $99, takes about 5 minutes to scan, and you can actually have a much more crystal clear picture about what is their heart risk. And it gives us a scoring anywhere from 0 to I've seen scores as much as 4,000. And we can kind of drive more into, this is your risk, not only your risk, but this is actual disease you have or the lack of disease that you have. So you actually are making sure you are treating the patients who need to be treated and also not over-treating the patients who might not need statin medication. Then how do we use that? So we have here some guidelines to say if you have a calcium score greater than 1, or if you're in the 75th percentile for your age and gender, particularly if you're above age of 55, you would probably benefit from having the statin therapy. And that can increase, that medical therapy can increase even some more when you have a calcium score above 100. So now you can add aspirin to decrease your platelet aggregation. So combined with statins and aspirin, you're really providing your patient plaque-modifying therapy in your office. Again, this is just a different way of visualizing what we've achieved with our patient. Yes, everybody gets to calculate it. You calculate that ASCVD risk score in your patient. That's most of our patients. Now you use risk enhancers to really personalize that risk. Somebody with maybe a borderline LDL of 120, it might be 7% on the ASCVD risk calculator, but you actually check their lipoprotein A, that's very high. Now you've just changed that person's risk from 5 or 7% to 15, 20%. You've actually clearly identified who this patient is and what kind of treatment do they need. On top of it, you are reclassifying that risk. Yes, they have lipoprotein A, but they have a calcium score of 200, then you're really going to increase your targeted therapy. Or let's say maybe they don't have a lot of plaque, you can go back to talk about their lifestyle, their diet changes you can do. So again, you're really kind of driving down not just overall risk, but the risk of your patient that's in front of you, and you're using these tools to kind of make that assessment. So we'll go on to seeing how CT coronary angiography can add to that. This is another diagnostic tool in our toolbox while we're trying to determine what is my patient's risk. So CT is a most non-invasive way to evaluate coronary artery disease. It is particularly helpful in a patient who has non-acute chest pain and no history of CAD. They've got some risk factors and their symptoms are definitely making you concerned. CT can actually be your first line to evaluate what's causing my patient's symptoms. It can also be particularly helpful in low to intermediate risk patients. Discharge CTA study was done to show that you can safely triage patients with a CT within a few minutes when coming in for chest pain and no previous history of CAD. You're able to either send them home, discharge them same day, or admit them for further evaluation. CT particularly shines in ambiguous results, such as maybe you have a history of a normal stress test, and now you're having more symptoms, or maybe an intermediate risk or inconclusive stress test. That's really gives you more clarity in what's causing my patient's symptoms. And also, again, adding to that, really driving down what is causing my patient's heart failure. When you diagnose heart failure, the particularly low-risk patients, you can use CTA rather than a coronary angiography to see if they have ischemic or non-ischemic heart disease. Again, there's other applications, more anatomical applications, if you're suspecting somebody to have a coronary anomaly, or if you want to assess their bypass grafts. This is a great way to do non-invasive testing. Again, this is from the chest pain guidelines from a couple of years ago that show you that the CT is actually first line to using therapy over exercise stress test. So think about your stable patient with chest pain and no history of CAD, CT can be first line. This is one of my favorite slides because it kind of shows you how normal stress tests can look like. A normal stress test can absolutely look normal with normal coronaries, but it can also look normal when you have mild, non-obstructive calcified disease. And this particularly on the most left side shows you that you have completely no plaque whatsoever, calcified plaque, but this patient does have a high burden of soft, non-calcified plaque, which also puts them at high risk for having an acute coronary syndrome. So again, all of these can look normal on a normal stress test, but CT gives you extra visualization into exactly what their coronary anatomy is. And I used this slide a few years ago to say that CT is difficult as an interpreter to see through the plaque and see the actual lumen. So I'm happy to say we have new technology that helps me exactly see clearly what is beyond that calcified plaque. So clearly the software we've implemented at Heart and Vascular, we've been using it for about a year now. It's an AI, FDA-approved software for assessing coronary plaque. So it's using advanced technology on the scans we've already done for our patients. It helps to quantify and classify the type of plaque, and also provides a detailed description about soft plaque. It's adding texture, what kind of plaque does our patient have? Do they have the calcified one that's a little bit more stable, or do they have a non-calcified high-risk plaque that makes them high risk for having a heart attack? So this is kind of what the screenshots look like from when we send patients for advanced lipid analysis. You can tell that the yellow could be your calcified plaque, blue can be your non-calcified plaque. So it just really gives you, and segment-wise, where is the plaque, what does it look like, how much is it? And we can also add ischemia analysis on top of it to say, well, this is actually where not only my patient has stenosis, but they actually have ischemia. And this is kind of the pictures that we look at to say it's kind of highlighted in red, saying this vessel might benefit from actually having an intervention. How do they use that? So it's AI analysis. It's going through over 40,000 patients' data sets of invasive data analysis to kind of come up with an algorithm to say, if you have these types of findings on CT, you're more likely to have ischemia. Again, this is another visualization of that same ischemia blood vessel. I do really want you to appreciate here that it's giving you different areas of plaque. This is calcified, non-calcified, what location again, and that something might benefit from interventions you would want to. So you're really giving a complete roadmap, a complete detailed analysis before the patient's ever stepped into a cath lab needing an intervention. So this is the value of having additional imaging tools to really say, what's my risk? And not only that, move beyond and say, how do we prevent a heart attack? So this is just comparing CT FFR with Clearly. I think heart flow is something that we use typically in the hospitals, but Clearly is basically machine learning, and it gives you more detailed plaque. Again, what type of plaque is it, where is it, how much is it, and it can also aid in preventing, because you actually can do this in asymptomatic patients who just want to know, what's my risk? Again, to summarize, Clearly has been a game changer. You are really able to visualize, characterize, quantify the plaque the patient has before you do any kind of procedures for them. You can actually start early disease detection and prevention. You can start them on a statin and aspirin, actually have actionable guidance to not just doing a CT scan. It also helps you in the patients who might consider high risk, maybe they have a high LDL, but they absolutely have no plaque. Well, now they have a choice. Do you want to be on medicine, or do you want to try everything you can through diet and lifestyle changes to determine this risk? So you're really driving down that personalization therapy, evidence-based personalization, individual care based on the patient's actual plaque burden, disease burden. Again, not everything is great for everybody, so you always want to remember you want to avoid this in patients with advanced CKD, any allergy to contrast, and they're not able to stabilize their heart, because if you can't get good imaging clarity, not even AI can read that study. So always remember, you have to have certain factors before you're determining if somebody is appropriate for the scan. And yeah, I make the high calcium score. I used that in the past, but now we know we have additional information and technology that we can apply to even read those patients with a very high calcified plaque. There are some downsides. Obviously, there is some radiation that's involved with this, but I think it's a little bit more than natural background radiation, it would be similar to maybe 2 mammograms that you have to get for your patient. That's some way you can counsel them. And as well as, so again, this is where we talk about, again, driving down the who is appropriate patient for the CT scan. Always think about the best option for low risk or intermediate risk, stable patients who have no history of CAD. This should be your first line. Patients who've already had, maybe they have diabetes, maybe they've had other kind of diseases, and you want to think about them as high risk for having CAD. Maybe you want to do a perfusion study like a stress test or a PET CT. Okay. So again, age is kind of, it's there, but honestly, it really just depends on your patient's risk factors. And again, this is the body of evidence that is supporting CT, and most recently, just in the 10 years, we've seen more analysis on CT-guided, whether it be discharge, prevention, as well as use of AI. So it's really newer technology. It's been there for a while, but the way we're applying it in cardiology, I would say, has only been seen in the past 5 to 10 years. And again, this is just a list of other trials that have kind of changed the course of how we use CT before we do any kind of procedures. So putting it all together, I kind of want to emphasize again that we've shown you that you have ways to personalize your patient's ASCVD risk using those risk enhancers. Again, that could be family history of preeclampsia, or an abnormal lipoprotein A. Again, we've talked about how just calcium scoring, that low cost, high value of seeing the plaque burden, how it can change and inform decision making, and you can start medical therapy before they ever have an event. As well as we talked about how CTA can now give you that actionable item. You can actually see how much plaque they have, where is the plaque, and talk to your patients with more substance and more depth about this medicine is going to decrease this amount of plaque for you, this aspirin is going to help you prevent a heart attack. So hopefully we kind of reiterated that for you today. And after all this, your patients still don't want to take a statin, you can call me. I'll be your support.